Welcome back to Let's Talk About It, a social work podcast where this season we're exploring the disparities experienced by Black veterans within the Veterans Administration. I'm your host, Edward Parati Sousas. If you've been with us since episode 1, you know we've been building this conversation step by step. In the first episode, we defined the problem, introduced critical race theory as a guiding lens, and laid out the gaps, naming how trust has been eroded and why this podcast exists to bridge knowledge and power. In episode 2, we dug deep into history, showing how racism in the United States, from slavery to Jim Crow to redlining and military exclusions, still shapes how Black veterans experience the VA today. Episode 3 turned to the very personal question of pain, respect, and being believed, highlighting how mistrust gets broken in everyday clinical encounters. In episode 4, we opened up the claims process and saw how the same diagnosis could yield very different decisions depending on race. Episode 5 turned to women's health, making clear how racism and sexism collide for Black women veterans. And in episode 6, we argued that intersectionality isn't optional. It's the only way to see the overlapping systems that shape Black veterans' lives. Today, in episode 7, we're going to widen the lens again. Our focus is on climate, representation, and the rollbacks of DEI initiatives, which is diversity, equity, and inclusion. We're asking, what happens when the institutional scaffolding that's supposed to support equity gets ripped away? What happens when diversity and inclusion are no longer priorities at the system level? And how does that impact the daily realities of Black veterans? Let's start with representation. Research has shown that representation is not just symbolic, it literally saves lives. In a 2023 study by Snyder, the author found that counties with more Black primary care physicians had longer Black life expectancy and lower mortality rates. In fact, every 10% increase in Black physician representation added about 31 days of life expectancy for Black residents. That's not just optics, that's survival. For the VA, this matters deeply. When Black clinicians are underrepresented in the system, Black veterans face cultural gaps, lower trust, and measurable health risks. Now let's talk about climate. Research by Rosen et al. Back in 2014 looked at VA disability exams for PTSD and found that while Black and white veterans rated examiners similarly on technical competence, Black veterans rated them lower on interpersonal qualities like respect, fairness, and listening. In other words, climate is about more than skill. It's about whether you're seen and respected. Later, Huseman et al. In 2020 reinforced this point, finding that veterans who perceived discrimination in care were less likely to engage and reported worse health outcomes. And VA's own National Veteran Health Equity Report in 2023 and the Black Veteran Chart Book both confirm persistent racial disparities in patient experience and chronic disease management. Climate isn't abstract. It lands in the exam room, in the waiting area, in real encounters with real consequences. So what happens when DEI gets rolled back? On January 20th, 2025, a new executive order directed federal agencies to eliminate DEI programs. By June, the VA rescinded Directive 5975, its policy framework for diversity and inclusion. Agencies were told to identify DEI staff, offices, and activities for reduction or elimination. The operational effect is clear. Fewer resources for training, fewer supports for workforce diversity, less capacity to monitor equity. As scholars like Zambrana 2017 and Snyder 2023 remind us, the absence of culturally competent frameworks and diverse staffing perpetuates mistrust, disengagement, and worse outcomes. For Black veterans, who already report lower trust and higher experiences of disrespect, this isn't an abstract policy change. It risks making every clinical encounter harder and every claim less accountable. That doesn't mean equity work disappears. It means we need to be even more intentional, Researchers like Woodward et al. In 2019 have developed frameworks like the Health Equity Implementation Framework, which offers practical tools for embedding equity into everyday practice, whether or not the work carries a DEI label. VA's own Black Veteran Chartbook, released in 2023, provides data that cannot be ignored. It shows both progress and persistent gaps. And researchers like Mfantuji in 2022 and Heath in 2025 have emphasized that centering community-informed, intersectional approaches is the only way to move forward when institutional backing is unstable. So, here's where we're headed in this episode. First, we'll dive into representation, why it matters for outcomes, trust, and the daily lives of Black veterans. Then we'll explore climate, showing how discrimination and interpersonal disrespect continue to shape care experiences. And finally, we'll take on the hard question: how do we operationalize equity in a post-DEI era? What tools and frameworks remain? What risks are emerging? And what steps can veterans, clinicians, and leaders take to keep equity alive in practice? Because here's the truth: veterans don't experience executive orders. They experience climate. They experience representation or the lack thereof. They experience equity or inequity in the care that they receive and the claims they file. And that's where we need to keep our focus. When we're talking about representation, we're not just talking about diversity posters or glossy brochures. We're talking about who is actually in the exam room, who greets you at the front desk, who runs the clinic, who reviews your claims file. Representation is not abstract. It's part of the daily experience of being a Black veteran in the VA system. And it matters for health, for trust, and even for life expectancy. Let's start with the evidence. In 2023, Snyder et al. Published a study where they wanted to know whether representation of Black primary care physicians at the county level had any measurable impact on Black health outcomes. They analyzed data from 1,618 counties across the United States, comparing physician demographics to life expectancy and mortality rates of Black residents. Their findings were striking. For every 10% increase in Black physician representation in a county, Black life expectancy increased by about 31 days. They also found that higher representation was associated with lower all-cause mortality and a smaller Black-white mortality gap. Pause on that for a second. A month of life expectancy gained just by increasing representation. Not by inventing a new drug, not by opening a new hospital wing, but simply ensuring that the people providing care more closely reflect the people receiving it. That is powerful. And it underscores why representation is not a symbolic issue. It's a survival issue. Now, why does this matter for Black veterans? First, because VA patients don't exist in isolation. Veterans use both VA facilities and community-based providers. If the local healthcare workforce lacks Black representation, that affects the quality and trustworthiness of care inside and outside of the VA walls. Second, because the VA itself has long struggled with workforce diversity, particularly in leadership and specialty care, studies have shown that minority clinicians are underrepresented in higher paying specialties and in administrative leadership roles, which means decisions about policy, resource, allocation, and priorities often happen without Black voices at the table. And this was found by Zimbrana et al. In 2017. Let's look at the numbers. According to the VA's own Increasing VA Workforce Diversity brief released in June 2023, in fiscal year 2020, the VA's permanent workforce was composed of about 57% white employees, 25% Black or African American, 7% Asian, and 8% Hispanic or Latino. At first glance, having 25% Black employees may sound promising, but we need to compare that to leadership. physician, and senior staff roles, and to the veteran population. A 2021 analysis published in U.S. Medicine found that while Black employees made up 25% of the VA workforce, only about 7% of the highest paid positions were held by Black employees in 2021. So representation at the entry level is one thing, but representation in decision-making roles is another. Even more striking, the broader U.S. healthcare workforce is still far less representative than the population. For example, data from the Kaiser Family Foundation show that while Black people make up roughly 12% of the U.S. population, they comprise only about 6% of active physicians. According to the American Association of College and Nursing, among registered nurses in 2022, only 6.3% identified as Black or African American, whereas 80% were white. These gaps show up in every corner of care, including those that serve veterans. We also have to recognize the changing veteran population. According to the VA's Office of Health Equity, projections indicate that the proportion of non-Hispanic white veterans will fall from 74% to 61% between 2014 and 2043, while the share of Black veterans will increase from around 12% to 15% in that period. That means that the VA workforce must shift if it is going to align with the veterans it serves. Representation also shapes trust. In episode 3, we talked about how Black veterans often report not being believed when they describe pain. That experience isn't just about individual bias, it's also about structural absence. If a veteran never sees a clinician who looks like them, or who shares some part of their cultural frame, mistrust builds. Hoffman et al. In 2016 documented how medical trainees often still hold false beliefs about biological differences between Black and white patients, like the idea that Black people feel less pain. Those stereotypes don't just vanish. They're reinforced in environments where representation is missing and where bias training is underfunded or eliminated. It's also about retention. Black clinicians are more likely to leave institutions where they feel isolated or unsupported. Zambrana et al. In 2017 wrote about the toxic ivory tower effect, where underrepresented professionals face higher stress, lower mentoring, and greater pressure to serve as the diversity representative on committees, without the same rewards or promotions as their peers. Within the VA, the DEI programs are rolled back. The structures that once provided mentorship, affinity groups, or accountability mechanisms for discrimination complaints may disappear. That means fewer supports to retain Black staff, which in turn means fewer Black clinicians to serve veterans. Representation is also about leadership. A veteran's experience of the VA is shaped not just by their doctor or nurse, but by the policies set by directors, chief of staff, and regional administrators. When leadership lacks diversity, blind spots grow. For example, the National Veteran Health Equity Report in 2023 shows persistent disparities in patient satisfaction, chronic disease management, and preventative screenings among Black veterans. Addressing those disparities requires leadership willing to prioritize equity. Without representation at those decision-making tables, equity can slip to the margins. And here's where it ties directly to the 2025 DEI rollbacks. In January 2025, the executive order directed federal agencies to eliminate DEI initiatives. By June, the VA rescinded Directive 5975, which had provided an internal framework for diversity and inclusion. Offices and positions dedicated to workforce diversity were identified for reduction or elimination. That's not minor paperwork change. It means fewer people tasked with tracking representation data, fewer resources for recruitment from historically Black colleges and universities, and fewer supports for mentoring programs that have been critical pipelines for Black clinicians. For Black veterans, that rollback translates into fewer Black clinicians in the pipeline, fewer Black examiners and claims evaluations, and fewer Black leaders shaping VA priorities. So what happens when representation gaps persist? Well, trust erodes. We've seen this again and again in the literature. Huseman et al. In 2020 found that veterans who perceived discrimination in their care were less likely to engage and reported worse health outcomes. Washington et al. In 2023 found that perceived racial discrimination among Black veterans was associated with lower ratings of communication and respect. Representation doesn't solve everything, but it is a critical piece of the puzzle that influences whether veterans feel safe, respected, and believed in their care. Representation also connects back to intersectionality. In episode 6, we said intersectionality isn't optional. The point is clear here. For Black women veterans, representation gaps in both race and gender mean they may rarely see clinicians who reflect their identities. For LGBTQ+ Black veterans, the gap can be even wider. Research shows that veterans who belong to multiple marginalized groups often face compounding experiences of invisibility. Without deliberate efforts to recruit and retain staff who represent those communities, those veterans may continue to face climates that feel hostile, isolating, or unsafe. Let's also talk about outcomes beyond health. Representation matters in claims processing. The GAO's 2023 report highlighted racial disparities in VA disability benefit decisions, with Black veterans more likely to be denied even when controlling for relevant factors. Representation among claims adjudicators, both medical and non-medical, could influence how evidence is weighed, how credibility is assessed, and how fairness is maintained. If adjudicators overwhelmingly come from backgrounds with little understanding of structural racism, the risk of bias in decisions increases. Finally, let's humanize this. Imagine being a Black veteran walking into a VA clinic. You've already lived through structural inequities, segregated schools, discriminatory housing, maybe even inequitable treatment during your military service. You walk into a clinic and see no one who looks like you. Not the receptionists, not the nurses, not the doctors, not the leadership on the wall of photos. Maybe you've had past experiences where your pain was dismissed, where your symptoms were minimized, or where your claims were denied. How much trust are you bringing into that encounter? And how might that change if you were greeted by someone who shares some of your lived experience, or at the least works in a culture shaped by colleagues who do? Representation gaps are not neutral. They are structural inequities that translate into health inequities, trust inequities, and life expectancy gaps. Snyder's 2023 findings make it clear: representation saves lives. The VA's own equity report makes it clear: disparities persist when climate and representation are not prioritized. And the DEI rollbacks of 2025 make it clear: without intentional action, those gaps will widen, not close. So, as we move forward in this episode, keep this in mind. Representation is not optional, just like intersectionality is not optional. Representation is a lever for health equity. And in the absence of formal DEI frameworks, it becomes even more urgent to guard, measure, and protect representation at every level, from frontline staff to leadership. Because representation isn't just about who's in the room, it's about whether veterans live longer, healthier lives. And that's what's at stake. Let's turn now from representation to climate. Representation is about who's in the room. Climate is about how the room feels. And for Black veterans, climate inside the VA, whether in a clinic, a disability exam, or even a waiting room, can mean the difference between health and harm, between trust and withdrawal. We often talk about organizational climate as something intangible, like workplace culture. But for veterans, climate is embodied. It is lived in micro moments: the warmth of a greeting, the willingness of a provider to sit back and listen, whether their pain is believed, whether their military trauma is acknowledged with respect. Climate is not abstract. It is the felt quality of care. Take Rosen et al. In 2014, which looks specifically at African American veterans going through VA disability exams for post-traumatic stress disorder. These exams aren't small matters. They are the gatekeepers of benefits, income, and official recognition of service-connected trauma. Veterans describe them as stressful, intimidating, and deeply consequential. Rosen's team surveyed veterans after their exams, asking about examiner competence, fairness, and respect. Interestingly, Black and white veterans rated examiner competence about the same. That means they trusted the technical skill of the examiner. But when it came to interpersonal qualities like respect, empathy, and fairness, Black veterans consistently gave lower ratings. Pause here. That means the hard science part was equal, but the climate, the human part, was unequal. For a Black veteran, the technical exam might have been fine, but the feeling of being dismissed, minimized, or disrespected was present. And because these are disability exams, that interpersonal climate could affect not only how veterans felt, but what they disclosed. Imagine holding back your worst trauma symptoms because you don't feel the examiner respects you. That could directly affect your claim outcome, and it certainly affects your trust in the VA. Fast forward to 2020, Huisman et al. Conducted a study that looked across VA care. They asked veterans whether they had experienced discrimination in their health care. They then linked those responses to outcomes like engagement, satisfaction, and utilization. The results were sobering. Veterans who reported perceived discrimination had significantly worse engagement within VA care. They were less likely to attend follow-up appointments, less likely to adhere to treatment recommendations, and more likely to report poor health status. This is critical. Perceived discrimination didn't just hurt feelings. It hurt health. Climate translates into real outcomes. And that means if the climate feels discriminatory for Black veterans, we are looking at higher dropout, lower adherence, and worse long-term health trajectories. Washington et al. In 2023 adds another layer. They look specifically at communication in VA healthcare. Their findings confirm that Black veterans were more likely to report negative communication experiences, being interrupted, not listened to, not treated with respect, and not included in decision-making. Good communication is not an add-on. It's one of the strongest predictors of patient trust, adherence, and satisfaction. If communication is worse for Black veterans, it compounds the inequities we've already named. And importantly, Washington's team showed these disparities varied by region. That means local VA climate and leadership matter. Where leadership invests in equity and climate, disparities shrink. Where leadership ignores it, disparities widen. The VA's Office of Health Equity published the Black Veteran Chartbook in 2023. It confirmed that independent researchers found Black veterans consistently reported lower satisfaction with VA care compared to white veterans. The disparities showed up not only in communication and respect, but also in chronic disease management. For example, Black veterans had lower rates of blood pressure control, lower diabetes control, and higher hospitalization rates for preventable conditions. This is a climate showing up as outcomes. A veteran who feels dismissed may be less likely to return for routine follow-up. A veteran who mistrusts the system may skip appointments. Over time, that mistrust becomes hypertension crisis, diabetic complications, and higher mortality. These findings align with the broader healthcare literature. Williams and Wyatt in 2015 reviewed decades of research and concluded that racial bias in healthcare, both conscious and unconscious, remains a major driver of health inequities. Hoffman et al. In 2016 demonstrated that medical trainees often still hold false beliefs about biological differences between Black and white patients, such as believing Black patients have thicker skin or feel less pain. Those stereotypes don't vanish at graduation. They enter exam rooms, influencing clinical judgment. In 2020, Alassian et al. Published research showing that Black veterans disengaged from mental health care when they felt stereotyped by providers. They reported feeling unseen, misjudged, and stigmatized, which led them to stop treatment early. That's climate again, stigma and stereotype embedded in the care environment. Now let's bring this to today's policy context. In January 2025, the Executive Order directed the dismantling of DEI programs. By June, the VA rescinded its directives of 5975. The Office of Personnel Management and Department of Justice memos instructed agencies to identify DEI positions for elimination and to shut down DEI activities. So what does this mean for climate? It means the infrastructure that once monitored climate disparities through surveys, dashboards, and dedicated staff is being dismantled. It means fewer trainings on implicit bias and cultural humility. It means affinity groups that once supported minority staff may be disbanded. It means fewer safe channels for veterans and staff to raise concerns about discrimination. It means the VA is stepping back from its commitment to serve all veterans. Climate improvement requires feedback loops, measurement, accountability, and action. Remove the structures that collect and respond to climate data, and inequities persist unchecked. For Black veterans, that means the climate that already feels dismissive and discriminatory is at risk of getting worse, not better. Let's put this into lived terms. Imagine a Black veteran walking into a VA clinic. The front desk clerk avoids eye contact. The nurse calls them sir in a curt, dismissive tone. The doctor interrupts repeatedly, downplays their pain, and doesn't ask open-ended questions. The exam ends quickly. The veteran leaves feeling unseen and unwelcome. They may not return. Now imagine a different climate. The clerk greets them warmly, with respect. The nurse takes a moment to ask how things are going. The provider listens fully, validates their pain, and asks about both medical and social context. They explain options, invite questions, and affirm the veteran's service. That veteran leaves feeling respected. They come back, they engage, their health improves. The difference is climate, and it's measurable in engagement, adherence, outcomes, and trust. We've been building this theme all season. In episode 3, we said mistrust gets broken in pain care encounters. That's climate. In episode 4, we saw how the same diagnosis yields different decisions and claims. That's climate embedded in adjudication. In episode 5, we heard how Black women veterans often feel invisible in women health programs. That's climate shaped by sexism and racism together. And in episode 6, we argued that intersectionality isn't optional, because climate doesn't affect veterans equally. For a Black woman, a lesbian veteran, or a veteran with a disability in poverty, climate is compounded by multiple axes of bias. Here's the bottom line. Climate shows up as care. It is not a soft issue. It is the felt quality of VA care, and it shapes everything that follows, whether veterans open up, whether they engage, whether they trust, whether they live longer and healthier lives. And here's the risk. When DEI is rolled back, climate inequities become invisible again. Without equity dashboards, disparities remain hidden. Without training, bias goes unchallenged. Without accountability, discrimination complaints disappear into silence. The evidence is clear. Rosen, Huseman, Washington, the VA chart book, Hoffman, Alassian, Williams, and Wyatt, they all show the climate matters for outcomes. Climate isn't a luxury. It's a core to equity. It shows up in every appointment, every claim, every waiting room. And when climate fails, mistrust grows, disparities widen, and health outcomes worsen for Black veterans. So we've talked about representation. We've talked about climate. Now we turn to the question everyone is asking. What happens when the scaffolding of DEI is rolled back? What tools remain? What strategies can veterans, clinicians, and leaders use to keep equity alive in practice, even when DEI is no longer the label? Because here's the truth. Veterans don't experience acronyms. They don't experience executive orders. They experience care and equity, whether named or unnamed. It has to be operationalized. Let's start with what changed. In January 2025, the federal executive order directed agencies to eliminate DEI initiatives. By June of 2025, the VA formally rescinded Directive 5975, which was its long-standing diversity and inclusion directive. The Office of Personnel Management issued instructions to identify DEI staff and offices for elimination, and the Department of Justice cautioned against maintaining programs that explicitly prioritize DEI. That meant the formal offices responsible for workforce diversity, training, and climate monitoring were weakened. Recruitment programs at historically black colleges and universities risk being dismantled. Mentorship programs for underrepresented clinicians lost funding. Equity dashboards stopped being prioritized. Now, whether one agrees with these policy shifts or not, the operational risk is the same. Inequities don't pause just because DEI programs do. Black veterans still walk into the VA. They still face disproportionate denials of claims, disrespect in clinical care, and worse outcomes in chronic disease. The question is, how do we continue equity work when the acronym is stripped away? One answer lies in the work of Elizabeth Woodward et al. In 2019, where they introduced the Health Equity Implementation Framework. This framework integrates equity into implementation science by asking teams to identify determinants of inequity at the outset of a project, select measures that capture equity gaps, and monitor whether interventions work equally for all populations. Think about what that means in practice. If the VA rolls out a new telehealth program, the framework insists we ask, who will this benefit most? Who might it leave behind? If broadband is required, are rural black veterans at risk of being excluded? If the program requires digital literacy, are older veterans disadvantaged? By embedding these questions into the rollout, not as an afterthought, but as a central measure, we operationalize equity. In 2021, Woodward et al. Published follow-up guidance, offering practical steps to use the Health Equity Implementation Framework, or HEIF. They encouraged identifying structural determinants like housing instability, racism, and poverty, linking them to clinical processes, and tracking disparities over time. This is not branded as DEI, it is branded as implementation science, and it remains fully permissible, even in a post-DEI landscape. The second strategy is to protect the data assets that already exist. The VA's National Veteran Health Equity Report and the Black Veteran Chart Book compile disparities in patient experiences, chronic disease, and quality of care. These reports remain public. They provide baseline data. Even if DEI dashboards are retired, these documents can be used locally and nationally to monitor trends. Leaders can download and preserve them. Clinicians can cite them. Researchers can build upon them. Equity work dies when the data goes dark. Protecting access to this data is essential. And remember, data is not just numbers, it is accountability. If veterans see their outcomes measured and published, they know the system is at least acknowledging the disparities. If data disappears, mistrust is just going to deepen. Transparency is a trust-building act. Third, reframe equity as quality and safety. Every health system tracks safety events, infection rates, medication errors. Why not track inequities with the same rigor? The VA is already a high reliability organization. That means it commits to zero harm. But if inequities are causing disproportionate harm to Black veterans, then equity is safety. For example, if Black veterans are more likely to have uncontrolled hypertension, that's a safety issue. If Black veterans report lower satisfaction with claims exams, that's a quality issue. Embedding equity metrics into existing quality dashboards makes equity part of a core business, not a side project. This is important in the post-DEI environment, because if leaders cannot fund a DEI program, they can still fund quality and safety. Equity can and should live there. Let's talk about training. With DEI programs rolled back, implicit bias trainings may be defunded, but training in communication, patient-centered care, and cultural humility remain permissible and essential. Evidence shows that this matters. In 2016, Hoffman et al. Found that medical trainees who held false beliefs about Black-white biological differences were more likely to underestimate Black patients' pain. Training that addresses these biases directly is critical. If the label implicit bias is politically fraught, reframe it as clinical accuracy training. After all, failing to recognize pain accurately is a medical error. Similarly, training in patient-centered communication, like those used in motivational interviewing, can improve trust, adherence, and satisfaction. These don't require DEI branding. They can be embedded in clinical continuing education under quality improvement. Another strategy is governance. In the post-DEI landscape, leaders can embed equity into existing committees. For example, quality councils can review disparities in outcomes. Patient safety committees can monitor inequities in adverse events. Women's health leads can review racial disparities in reproductive outcomes. Pain stewardship programs can monitor disparities in pain management. The point is not to create new DEI committees. The point is to distribute equity accountability across existing governance structures. That way, equity doesn't disappear when DEI is defunded. It remains part of how the system governs itself. Veterans themselves can and must be partners in operationalizing equity. This was a theme we set at the start of this podcast, centering Black veterans' authoritative knowledge. Veteran advisory councils can be structured to include Black veterans, women veterans, LGBTQ+ veterans, and other forms of marginalized groups. Their feedback should shape service design, policy priorities, and even research agendas. This does not require a DEI label. It requires commitment to participatory governance. And it addresses the mistrust we've documented all season. When veterans see themselves at the table, mistrust begins to heal. We should also be honest about the risks. If equity is not operationalized in these ways, disparities will worsen. The 2023 GAO report supports this. Without structures to monitor the correct inequities, these gaps will grow. And the research shows the consequences. Black veterans already have higher burdens of chronic disease. They already report lower satisfaction. They already face more mistrust. If equity is ignored, we are looking at widening mortality gaps, worsening disability, and deepening mistrust. Let's bring this down to one veteran, because equity always has to come back to a human level. Imagine a Black veteran living in a rural county. Broadband is limited, the VA rolls out a new telehealth initiative. Without equity planning, this veteran can't access it. Their chronic condition worsens, but if equity is embedded, if the rollouts ask who might be left behind, then alternative strategies are planned, like in-person outreach or mobile clinics. That's the difference between equity ignored and equity operationalized. Or think of a claims exam. A Black veteran with PTSD walks in. If the examiner is untrained in cultural humility, they may minimize symptoms, doubt credibility, or rush the encounter. If equity is operationalized, examiners are trained in patient-centered interviewing, outcomes are tracked by race, and disparities are flagged. That difference could be the difference between a denied claim and a recognition of trauma. This is what we've been building all along. In episode 1, we said critical race theory teaches us to see systemic inequity, not just individual bias. Operationalizing equity does exactly that. It embeds systemic analysis into practice. In episode 2, we said history shapes mistrust. Operationalizing equity acknowledges that mistrust and designs care around it. In episode 3, we saw how mistrust is broken in pain encounters. Operationalizing equity prevents that by training providers and monitoring outcomes. In episode 4, we saw how the same diagnosis yields different decisions. Operationalizing equity makes those disparities visible and correctable. In episode 5, we saw how Black women veterans face double invisibility. Operationalizing equity requires intersectional design. And in episode 6, we argued intersectionality isn't optional. Operationalizing equity is how we live that truth. So here's the takeaway. The acronym DEI may be rolled back, offices may be dismantled, directives may be rescinded, but equity does not disappear unless we let it. Operationalizing equity means embedding it into frameworks like Woodward's Health Equity Plan. It means protecting and using data like NVHER and the Black Veteran Chart Book. It means reframing equity as quality and safety. It means training for accuracy and respect. It means governance that owns equity across the system. And it means centering Black veterans as partners. Because veterans don't experience policy memos. They experience care. And when equity is operationalized, the care becomes fairer, safer, and more trustworthy. For Black veterans, this is not optional, it is essential. because the VA publicly rolling back DEI only validates Black veterans' perspective of mistrust. As we close out episode 7, let's take a step back and think about what we've covered. We started with representation. Who is in the room? Who provides care? Who makes decisions? The evidence is undeniable. Snyder et al. In 2023 showed that Black life expectancy literally increases in counties with more Black physicians. That's not a symbolic win, that's survival. And inside the VA, representation matters just as much. When Black veterans see providers and leaders who reflect them, trust deepens. When representation is missing, mistrust fills the gap. We then turn to climate, how the room feels. Rosen et al. In 2014 study reminded us that even when competence is equal, Black veterans report lower respect and fairness in disability exams. Huseman's 2020 findings confirm that perceived discrimination drives disengagement and worse outcomes. Washington's 2023 work showed communication gaps persist across VA facilities. Climate isn't abstract, it's lived in the waiting room, the exam room, and in the claims exam process. And when we looked at operationalizing equity in post-DEI era, policies have shifted. Executive orders have rolled back DEI programs. The VA has rescinded Directive 5975. But equity doesn't disappear unless we let it. Tools like Woodward's Health Equity Implementation Framework remind us we can bake equity into operations, whether or not we call it DEI. Data like the NVHER and the Black Veteran Chart Book keep inequities visible, and examples from Kaiser's Permanent and New York City's Health Plus hospitals and academic medicine show that equity can be embedded into quality, safety, workforce, and research, even without formal DEI programs. Finally, we made it practical. Veterans, clinicians, and leaders all have roles to play. Black veterans can raise their voices in advisory councils, service organizations, and in exam rooms. Clinicians can practice equity through respect, cultural humility, and self-audit of their own outcomes. Leaders can embed equity into quality metrics, protect data, and foster climates of respect. Everyone has a hand in building equity, even when formal scaffolding is removed. So where does this leave us? It leaves us with the truth that has echoed throughout this season. Equity is not optional. Representation is not optional. Intersectionality is not optional. They are foundations of trust, and without trust, the VA cannot fulfill its mission. I want to also be clear about the stakes. When equity is ignored, Black veterans pay the steepest price. They pay it in higher denial rates for disability claims, they pay it in undertreated pain, and they pay it in worse outcomes for chronic diseases. They pay it in mistrust that keeps them from walking back into the clinic. These aren't abstract costs, they're human lives. But when equity is operationalized, even quietly, even without the DEI label, the benefits ripple outward. Veterans live longer, trust grows, engagement improves, leaders make better decisions, clinicians practice more accurately, and systems become safer. So as we leave today's episode, here's the call to action. Keep equity alive in practice. Protect data. Embed equity into safety and quality. Build representation pipelines. Listen with respect. Include Black veterans at the table. And never let policy swings erase the truth that equity is essential to high-quality care. Because at the end of the day, veterans don't experience directives. They don't experience acronyms. They experience people. And those people, the clinicians, the staff, the leaders, have the power to create climates of respect, climates of fairness, climates where Black veterans can finally feel that the system sees them fully. This is not the end of the conversation. In fact, it's the setup for what's next. In episode 8, we're going to go over data, gatekeeping, and who sets the questions. Until then, remember this: equity is not a program, it's a practice. And it's a practice that saves lives. It's a practice that builds trust. It's a practice that builds safety into care. It's a practice that sees and serves all veterans equitably. As always, remember to share this with a battle buddy, a clinician, or a leader who could benefit from this, and together we can continue to amplify and center the voices of Black veterans everywhere. Until next week, I'll see you then.